Hi everyone, we're going to talk about Chapter 29, Eye Disorders. There's a lot of information here, so I'm going to try to break it up into 20-minute videos. So the first thing we're going to talk about is some standards that have been set up by the Healthy People 2020, and part of that is to increase preschool children receiving vision screening. One of their goals is to reduce blindness and visual impairment in children, reduce uncorrected refractive errors, increase the use of personal protective eyewear when in woodworking, sports, etc. There's also a U.S. Preventative Task Force that is providing screening tests to identify strabismus, amblyopia, and refractive disorders. There are several organizations that are focused on finding that we do well child exams that include ocular history, include a vision assessment, do external inspection of the eyes, and assess for ocular mobility. We also in practice need to evaluate for fixing and following. So any child that has inabilities after 3 months of not having a correction with an issue needs to be referred. The American Association of Pediatric Ophthalmology also recommends that we refer high-risk children and those when screenings appear inaccurate, family history of eye conditions, or multiple health problems. So we're going to talk a little bit about anatomy and physiology of the eye, and if you will look at figure 29.1 in the book, it talks a little bit about more of the structure of the eye. And so here we have an example of that, not the exact one from the book, but another one that I found. The eyeball, we know, consists of 3 layers. They're the fibrous tunic, the vascular tunic, and the inner tunic or the retina. The fibrous tunic consists of the sclera and the cornea, and the vascular tunic, which is the middle layer, is composed of the choroid, the ciliary body, and the iris. The structures of the eye are dedicated to helping provide accurate and efficient functioning of the retina. So the purpose of the eye is to focus on light rays, and it has 4 basic processes. We have refraction of light rays, which means bending as they pass from one medium to another. We have accommodation of the lens, and that focuses on the ability of the lens to focus close objects by increasing the curvature of the eye. Constriction of the pupil, which is contraction in response to light, and convergence of the eyes is done by medial rotation to allow light rays to hit the same point of both retinas. Potential problems with the eyes or the visual system can take the form of specific disorders, infections, or injuries to the eyes, and these can include some refractory errors such as myopia, hyperopia, astigmatism, and anisomopria. We also have strabismus, amblyopia, ptosis, nystagmus, cataracts, glaucoma, retinopathy of prematurity, retinoblastosis, and infections, injuries, and systemic disorders and medications. And so we're going to talk a little bit more about those. So when you go in to do an assessment of the eye, it's as with all body systems, it's important to get a thorough history. We want to do a careful exam and then utilize certain screening tests. Some questions that you may want to ask is a bit about the child's general medical history, any family history that might be impactful to the eyes, any eye issues for anyone in the past, any history of chronic systemic diseases, allergies, medications, any ocular history, last time their eyes were seen, eye injuries, prescriptions, any symptoms of eye dysfunction or disease, such as loss or change in vision, sensitivity to their sight by bright light, swollen eyelids, itching, tearing, blinking, or any redness in the conjunctiva area. On physical exam, the eye may be challenging to examine depending on the child's age. It's important that the exam be done quickly to account for the child's short attention span. Knowledge of and the developmental milestones for vision are important to know, so be sure and look at Table 29-1 when doing a gross inspection. Also look at external structures with a pen light, the lids, the conjunctiva, the cornea, the lacrimal structures. Check for the size and the symmetry of the pupils, their reactivity, the orbits, eye muscles, and their balance and movement. Also check for the red reflex. It can be checked at all ages and needs to be looked at for color intensity and clarity. A kind of rule of thumb is if you can't see into the eye, then the patient can't see out. Also, with kids 5 and older, a fundoscopic exam should be conducted, and this is going to visualize the retina, the choroid, the fovea, macula, optic disc, and cup, and the entry and exit of the nerves and the vessels. And if there's any concerns for growth parameters to the head or neck, these need to be examined at that time as well. So some screening tests that we're going to perform is the red light reflex, and that's also called the Bruckner test. And it should be done at every well exam. So you need to darken the room so you can see more of the subtle asymmetries, look at the pupils simultaneously and separately, and any asymmetry such as darker white spots, any opacities, or leukorrhea requires further investigation or referral. And so infants with a family history of retinoblastoma should be referred at 1 to 6 weeks for an ophthalmological exam with an ophthalmologist. Visual acuity screenings for both near and far distance should be performed on all children during routine physical exams so that problems that may be suspected can be identified. Look at tables 29-2 and 29-3. Children who are not reading at grade level after 5 years of age should have a formal visual acuity screening completed because it goes without saying if a child wears glasses or contact lenses, then that visual acuity measurement should also be obtained using those corrective lenses. So if you're doing a vision test on a child who wears glasses, be sure and conduct that test on the child while they're wearing the glasses. It does no point to do that if they don't have their glasses or corrective lenses in place. So when doing eye exams on kids, make sure that when you're checking their vision, if they wear corrective glasses or lenses, be sure to have those in place. Also be sure and to assess for some color vision testing. So let's talk a little briefly about some screening tests. You can find more about them in your chapter, but looking at your peripheral visual fields provides information on retinal function, which is the neuronal visual pathway to the brain, and it tells us a lot about the function of the cranial nerve 2, which is the optic nerve. In an infant, the assessment is limited, and you can check peripheral visual fields by watching the child's response to familiar objects. So if you bring in a rattle or a bottle from different perspectives, you can kind of assess their assessment. As children mature, they can cooperate more and visual fields can be better measured along with finger countering. So some peripheral visual fields should be, some parameters should be approximately 50% upward, 70% downward, 60% towards the nose, and 90% outward. For testing ocular mobility and alignment, you conduct the Hertzberg test, which assesses extraocular and muscular function, and refer to the book for details of this exam. If your concern is for visual disturbances, it's important to assess the child's visual functionality. And so one test that we can do for that is to take a pen light and move it in from a lateral position and turn the light on and off several times to assess light perception. If the child can see the light on and off, then the vision described, as LP for light perception. You can also move your hand back and forth with periodic stopping about 12 inches from the child's eye And if they are able to see you move your hand back and forth, you need to document that as the distance that it is, such as HM at 1 foot. There's more of this clarification in the book. Also, you can assess counting of fingers this way. If you're needing to conduct some diagnostic tests based on what your concerns are, some that are common with eyes include culture and gram stain of eye discharge. You could order ultrasounds, CTs, MRI of the orbits for cellulitis to rule out trauma or any tumors. It's important not to use ultrasound if you have concerns for a ruptured globe. You don't use an MRI if there's concern for a metal foreign body in the eye. And then fluorescein staining is used to determine any corneal damage. So let's talk a little bit about some management strategies. Be sure and review Table 29-4 for a comprehensive pediatric medical eye evaluation to clarify a little bit more about who they might need to see based on the pathology of what you're finding. So if you're concerned about the pathology of the eye, you need to refer your little one to the ophthalmologist. If you're concerned for refractory errors such as vision and some common conditions, an optometrist can take care of that. If you're concerned about strabismus or improvement or prevention of amblyopia, that may require occlusion of the eye, so patches. And then if you're concerned about refractory errors, then you're looking at corrective lenses, contact lenses, glasses, etc. When we think about eye medications, we need to use caution as peds are smaller body mass. They have faster metabolism, which may allow the drugs to be more accelerated. Topical agents are primarily used for the anterior eye segment. Sorry about that. Let me see if I can get that off. So topical agents are primarily used for the anterior eye. Water-soluble products are good for penetrating the corneal epithelium, and then fat-soluble products need to be in places where you're not going to need to penetrate the epithelium. So some topical antibiotics should be, your choice of that should be based on empirical evidence of the infection. The best choice of antibiotic is one that is often not prescribed for other problems in the body. Your fluoroquinolones and your sulfa drugs are very effective in the eyes and rarely produce any hypersensitivity reactions. It's important to avoid any topical penicillins, and ointments are preferred for kids as they last longer and they don't sting. In regards to ophthalmic corticosteroids, those are used with the treatment of eye inflammation or a traumatic iritis. You need to make sure that you're not dealing with an ocular allergy. And so a patient that has a condition severe enough to warrant using these drugs needs to be referred to an ophthalmologist. Some complications that can happen with corticosteroids in the eyes are herpes simplex keratitis, corneal ulcers, fungal keratitis, corneal perforations, sepsis, cataracts, and permanent loss of sight. And also you have to assess these patients for adrenal suppression if they've been on steroid eye drops. Other topical preparations include decongestants or antihistamines, mast cell and stabilizers, NSAIDs. There are over-the-counter vasoconstrictors and antihistamine preparations that can be used for allergic conjunctivitis. And then there is cycloplegic agents that are used for iritis, and those include like your atropines and your scopolamines to help with those issues. Some systemic medicines that are used may be for infections involving the orbits. You can also have combinations of topical and systemic antibiotics. those are typically managed by ophthalmologists. And if you look on table 29-5, it will give you more information on some systemic drugs that may damage the eyes. So, for eye injury prevention, ocular traumas account for about 1/3 of all cases of acquired blindness seen in kids. The male to female ratio is approximately 4 to 1, with males in the 11 to 15-year-old category outnumbering all other age groups. It's important to wear protective eyewear, and about 50% of all injuries are related to sports. Other causes may include ocular traumas, birth issues, being poked in the eye, fireworks, airbags that have deployed. It's important to educate children about safety of their eyes as well as parents. They should be taught to wear protective eyewear, to not shine laser pointers in the eyes, and to use eye wash fountains when indicated. Parents should also be instructed to store harmful chemicals and sharp objects out of the reach of small children, and to supervise the use of BB guns, air rifles, paint ball devices, darts, and fireworks. So I will let you read these, as they are pretty common sense on what we need to do to prevent eye injury. So there's some discussion on the use of vision therapy lenses and prisms to treat learning disabilities and dyslexia. And the American Association of Pediatrics has made a statement that there's not sufficient evidence to support that vision abnormalities cause disabilities, including dyslexia. The recommendation for vision care for children with learning disabilities includes periodic vision screening, as with all children, and if there's a suspected or diagnosed learning disability in which vision plays a role, the parent should be referred to an ophthalmologist. Ophthalmologists should identify and treat any significant ocular or visual disorders that are present at the time. So let's talk a little bit about visual disorders. And I will apologize in advance if I butcher some of these words. So when we're looking at issues with the refractory power of the eye, we can include those for myopia, hyperopia, astigmatism, accommodation, and anisometropia are some of the common alterations that we see. Be sure and look at box 29-4. Sorry, it's box 29-2 that'll give some more descriptive terms for these eye conditions. In normal eyes, the light from a distant object focuses directly on the retina, and when there's variation in the length of the eyeball or a curve of the cornea, the light lands differently and it focuses in the front or behind the retina. This abnormal focusing produces a change in the refractory power of the eye and results in a visual deficit. Okay, so amblyopia is usually a unilateral deficit where there is a defective development of the visual pathways needed to attain central vision, and clear focused images fail to reach the brain and can result in a reduced or permanent loss of vision. The condition is labeled according to the structural problem that causes the poor vision. So we have the deprivational, which is obstruction of the vision, or the strabismic, which is a lazy eye, or refractive, which includes the myopia, the hyperopia, astigmatism, and the anisometropia. These refractive areas are most common in kids. Approximately 30% of the pre-adolescent children can have refractory errors such as these listed. So let's talk a little bit about some refractive errors and amblyopia. That is typically seen with squinting, tiredness of the eye, headaches, which may be rare though, pain, dizziness, nausea. You may see some developmental delays, and there's a positive family history associated with it. Treatment of it refers to a good eye exam and may require prescriptive lenses, annual exam if wearing glasses, and unilateral visual occlusion may be necessary. Some of the complications that are seen if this condition is not treated, you may have some irreversible loss of vision. In strabismus, it's a defect of the ocular alignment or the position of the eye in relation to others. It's often called lazy eye, where one or both the eyes appear crossed, and since the visual axes are not parallel, the muscles of the eyes are not coordinated. Some clinical findings of this include intermittent extropia in normal children anywhere from 6 months to 4 years when tired. So it's more pronounced as the child is tired. The child fixates with the unaffected eye. The angle of deviation may change in different fields of gaze. You may see some persistent squinting or head tilting, and you can also have some associated cataracts, RB, anisometropia, and refractive errors are often infrequent. In the strabismus, the corneal light reflection test and the uncover cover test and alternating cover test are used to screen for it. Asymmetry of light reflection on the cornea is an indicative of a deviation in the ocular alignment. So management would be to refer to an ophthalmologist of greater than 4 months. They may do an occlusion of the unaffected eye for about 2 hours a day. There may be use of corrective lenses, monitoring. You need to monitor siblings to see if they're having any issues with it as well. Complications might be some secondary vision loss. Blepharoptosis is the drooping of one or both eyelids. It can be congenital or acquired. Management requires a referral to an ophthalmologist. If there's any underlying systemic diseases, those need to be corrected in patients so they can be evaluated for anisometropia, which is an equal refraction for each eye. So nystagmus is the presence of involuntary rhythmic movements in the eye. When assessing for nystagmus, it's important to know as much about the movement as possible. Is it up or down? Is it sideways? Is there a certain amount of oscillations per time? The distance of movement? Does posture of the head change? These patients are ones that need to be referred to an ophthalmologist, but you can provide a lot of information before being referred to an ophthalmologist. Cataracts, as we know in adults, is a partial or complete opacity of the lens that affects one or both eyes and are categorized as either being congenital or acquired and are most often isolated findings. They can occur spontaneously. They can be genetic, such as with Down syndrome or albinism. They can also be associated with maternal prenatal infections or drug exposure. Management includes monitoring and referring to an ophthalmologist. Prognosis is dependent on the type and the presence and what other abnormalities might be seen at the time. So glaucoma is an issue with the distribution of the aqueous fluid that results in increased intraocular pressure and damage to the optic nerve. Clinical findings may be where you have increased tearing, photophobia, excessive blinking. There may be some hazy corneas or corneal edema. Secondary clinical findings may be pain in the eye, blurred or lost vision, tunnel vision, dilatation of the pupil, and redness. Early diagnosis of glaucoma in kids is very important. The goal is to normalize the intraocular pressure and to prevent any optic nerve damage. These kids need prompt referral to an ophthalmologist. Primary treatment is typically surgery and medications that can be used as part of medical management. These kids can also suffer from other complications such as myopia, amblyopia, or strabismus, and there's always the potential of permanent vision loss. So we're a little bit past our first 20 minutes for this chapter. We're going to end this one, and then we will start off again with another topic. Hold tight.